Hello, and welcome to the Clinical Care Options Infectious Disease Podcast. I'm your host, Jacqueline Meredith. This episode features content from an educational symposium titled Ready, Set, Vaccinate, Clinical Implementation of RSV Vaccination for Older Adults, featuring Dr. Angela Branche from the University of Rochester, Dr. Pamela Rockwell from the University of Michigan, and Dr. Richard Zimmerman from the University of Pittsburgh. In this episode, they discuss the clinical presentation of RSV in older adults, as well as diagnostic approaches. To find more information about our expert faculty, as well as other activities from this program, including downloadable slides, please visit the link in the show notes for this episode. Now let's get started with Dr. Rockwell.
There's a wide range of clinical symptoms. We're talking about cold and flu seasons. With RSV, these symptoms can range from mild upper respiratory symptoms like a cold, moving all the way down the respiratory tract to a lower respiratory tract symptom, and then death, mortality. And historically, it has been underdiagnosed, but I think there is a lot of research now catching up. We've underestimated the burden of disease, not only on our patients, but the economic burden, what it does to our system. And influenza has been extensively researched, and COVID-19 is currently being researched with evolving variants, and clinical presentations keep on changing and evolving. I tried to look at where we had some evidence for how these things present. And with RSV, initially, they're mild URI symptoms with like nasal congestion, discharge, sore throat. As the viruses progress the lower respiratory tract, then symptoms might start to include some dyspnea, wheezing, some shortness of breath. Pre-existing medical conditions may be exacerbated, all the cardiopulmonary stuff. And adults present a little differently than kids too. But this little pictorial just shows you where it starts at the top of the head and then slowly moves its way down into the lungs. So what I could find data on was that RSV is a gradual onset of mild upper respiratory infections compared to influenza, which typically presents with an abrupt onset of more constitutional symptoms. You wake up, you're sick, you have a fever, you just feel tired and terrible, and you know you're sick. COVID-19 could be any of the above. It can start mild or start with constitutional, and data still coming in on that. So when looking at how to differentiate different complaints based on what data we do have, a runny nose is more likely with RSV than with influenza. That doesn't mean you might not have a runny nose with influenza, but more likely you're going to see it first with RSV. GI complaints, however, are more likely with influenza than with RSV. Fever can be there with all infections, but more likely and statistically shown to be prominent with influenza. And a cough, more likely to be present with influenza. I think if this were 2 years ago, we would say cough is also there with COVID. But now I don't think that is how COVID is presenting these days. The one unique symptom would be loss of taste or smell, and that is unique to COVID-19. This is a really nice little graph from FID, which is the National Foundation for Infectious Diseases. And the green boxes show where these symptoms are often seen in the disease. Yellow is sometimes, and red is rarely. The only often symptom for RSV is wheezing, interestingly enough, because I think the people who are presenting with RSV disease are at that point where they're wheezing. And they're not really presenting early on in their infection because they think they have a cold. So this is just a nice little reference point to look at. How do you diagnose RSV? We really need to do labs. We need a laboratory confirmation. Unfortunately, when you look at data for hospitalized patients, there is no universal definition. And when you try to compare different studies, you find that different studies have different criteria for their definition, aside from a positive RSV test. So the diagnosis may be difficult. As I said, compared to children, adults present a little differently. They, first of all, have lower viral respiratory titers in their secretions, and they have a shorter duration of viral shedding. The infections start mild, so they usually don't go to the doctor for a few days. They're not looking for testing or medical advice. And so by that time, they're less likely to test positive for RSV in their upper airways. So that is why one of the test question answers was incorrect with the rapid antigen test. So for the test that's best to diagnose adults with RSV, it would be the molecular PCR test. For children, the rapid RSV antigen testing is still recommended and quite sensitive. But the PCR test is what is required for adults. And if you're going to do this, it's the nasopharyngeal swab, and that's more sensitive than an oropharyngeal swab. We don't really use viral cultures too often unless somebody is in the hospital and they've been sick for a while and you really have to nail down what the diagnosis is. So combining a viral culture with a PCR can increase your sensitivity. And serology is not often used, and it's typically used in research studies. Why do we need to know for testing? There's really no good treatment for RSV, but since we can obtain these respiratory PCR panels to discern between RSV, influenza, and COVID-19, we can now better inform treatment for our patients. So we now have some treatment for antivirals for COVID-19 and for influenza. And so that'll help to at least tailor the treatment to your patient. How do we raise RSV awareness? This I'm going to open up to the panel.
I think it's public health education. There's certainly a lot of issues with health literacy or the lack thereof in many of our patient populations. I suspect that prior to the advent of the ads for RSV vaccines, that the vast majority of my patient panel did not know about RSV unless they were a healthcare worker.
Yeah, I agree. I had a patient just in my office the other day. I was trying to convinced to get the RSV vaccine. And she has never heard about RSV and wasn't sure if she wanted to be vaccinated or she needed to be vaccinated. I think we just have to have a lot of those conversations about what RSV is. We should put it in the context of flu and COVID because those are two infections they do understand. And I think once we make it clear that it is really a threat that is not a new threat, it's one we've known about for many years, we just didn't have anything to do about it, then I think that will help a lot.
And I do think the threat of hospitalization and death really works. And older adults are very savvy to know they need a flu shot and a COVID shot. And so when you tell them RSV is as common or even more, causing more morbidity, mortality than influenza in certain people, I think they're more likely to get vaccinated, or at least that has been my experience. But it does include a little talking. So key take-home points here are that RSV symptoms are nonspecific and can overlap with the other viral infections we typically see in the wintertime. We know now that pre-existing medical conditions may be exacerbated, especially cardiopulmonary disease. And the diagnosis may be difficult in the beginning because the lower respiratory tract virus titers are only obtainable through PCR and not through a rapid test.
Thank you very much to our faculty, and thank you to our listeners for joining in. To hear more episodes from this session on RSV, see the link in the show notes. And please be sure to check back for more episodes on important infectious disease topics. Thank you and have a great day.